Alright, so we're back with episode 3 of 911 and 864.
Right.
After a near-death experience.
Well, sorry for the delay. It was a tumultuous Christmas, if you will, but...
Hold on. What does tumultuous mean?
Rough.
Do you know what rudimentary means?
Yes.
What? Because if you don't, I will tell you.
Come on, let's tell our listeners.
Rudimentary means like basic, bare bone.
Right.
Ellie taught me that this morning.
Yeah, sometimes that's what I am, actually.
So, tumultuous Christmas. What happened?
Well, I'm going to tell you. So, of course, I was not a good patient, but it doesn't matter. So, we were scheduled to record Christmas Eve. I was paying bills, which may be part of the problem. But anyway, I was paying bills. I just had coffee. Like, everything was great. I got up because somebody was coming over to help me do something, and I had the worst pain. So I thought, like, oh, did I pull something? But, like, I couldn't complete a sentence. Like, I was breathless. And I was like, okay, this is pretty bad. And I mean, across here, up into here. And I was like, and then, like, you know, you're self-diagnosing. Of course, I bring this person to my house, and they're like, they're a paramedic. They're like, are you okay? And I was like, I don't know. Something bad's happened. Like, I knew it wasn't a kidney stone. Like, I went through all this stuff. I wasn't febrile. I was fine. And I was like, it's a little weird to be cardiac. I don't really have risk factors other than being overweight, but I don't have any, like, hypertension, diabetes, or any of that stuff. And I'm like, I don't think so. I did just come back from traveling, and I was like, I guess it could be a PE, but this is pretty sudden. And I was like, I'm not tachycardic, so what do I do as a physician but take 4 Advil and a handful of Tums, because that usually fixes most problems. So I took that and did a little EKG on my Apple Watch, which looked normal. Now, it didn't look bad. I mean, I know you're not going to diagnose a heart attack, and of course they told me all that on there, but I was like, I really don't feel like this is Now, the pain was, I have a really high pain tolerance. I know people say that all the time, but, like, didn't take anything when I had kids, didn't take narcotics, like, I'm not, nothing. I usually just take a Tylenol or an Advil, some here and there, okay? I put up with a lot. This was right up there with, like, this is severe. I thought if it goes to my back, I'm surely dissecting. Like, it was severe. Then I was on the ground. Then I was diaphoretic. My friend's like, should I take you in? And I was like, no, because, of course, like, I'm a horrible patient. So anyway, then it started to ease up a little. But while I'm going through this whole differential in my head, I'm like, I bet this is my gallbladder. I bet old girl has quit. Like, This is it. Here it is. And, like, in 2018, I had, like, 1 stone in there, and I saw a surgeon. He's like, well, at some point, you're going to have a problem. We'll just figure it out then. Here's my cell number, blah, blah, blah. Well, it's Christmas Eve, of course. So I'm like...
Yeah, because I called you, and, like, and it rang one time. It was like, sit in the voicemail.
Oh, it was bad. I did, like, a heating pan. I was trying to do stuff, like, it was too high up to be, like, anything lower. Like, I was going through this whole differential. So then it eased up some, and I had to work at 3 in APOD.
Yeah.
So I went to work because, like, I mean, what better place to be if I actually really needed to have something done? But then I talked to one of the surgeons there, and she's like, let's just get your blood work and get your ultrasound done. Like, you could have acute cholecystitis. And I was like, yeah, I guess so. But I haven't thrown up. But I probably could have thrown up from the pain. I probably could have.
That's how bad it was.
Oh, it was bad. And I'm like, I am just not a complainer. So I'm like, okay. Like, so, and meanwhile, got blood work drawn between traumas. We had 16 traumas during my shift. It was awful.
And you were still working?
Still working, and I'm going to tell you, I talked to so my labs looked a little abnormal, like my liver labs were elevated. I didn't have a white count, I wasn't febrile, I wasn't throwing up. I'm like, well, and the OR was full. I mean, overrun with cases. So they couldn't fix me anyway. So I'm like, well, what? I'm not going to call anybody in. I'll just work. Like, it is what it is. Anyway, so the ultrasound showed a bazillion stones, but no acute cholecystitis. I was like, okay, here's the scoop. So I talked to Dr. Simpson, who was on also, wonderful surgeon over at GMH, and he's like, was going to work on Sunday. So I was like, listen, I'm just going to eat non-fat, which is exactly what you want to do on Christmas. That's really what you should be doing, is eating a non-fat. Then I'll be NPO after midnight. Just let me know how it looks on Sunday. Like, I knew it was, like, who's going to do Christmas? Like, right. I didn't want that. So, anyway, the 26th in the early AM, he called me and was like, come on in, let's get this done. And I was in the ER for half an hour. Of course, my boss saw me as my provider and lectured me about how ridiculous it was that I was at work on the 24th.
It is ridiculous.
Well, he's like, this isn't conjunctivitis, Sarah. This is legit disease. And I was like, I know, but there is doctors out with COVID. There's other things going on. There was no spot for me in the OR. Like, I went through the process. If I was febrile and vomiting everywhere, like, I wasn't going to,
right.
play around with it. But, I mean, there was nothing they could do. So, anyway, Dr. Simpson, and he came down, saw me. I spent like 30 minutes in the ER, 30 minutes in pre-op. Mm-hmm. Anyway, he didn't clear me to go back to work until the 14th.
So I was worried about you. I'll be honest with you. I was worried about it.
It was bad.
Because when I talked to you the night before to confirm you were still good.
Yeah, I was
fine. Let's see. I was at the bowling alley.
Right.
And I was like, you still good for tomorrow? Because, I know that.
That was great.
Christmas Eve's rough, but...
That's
so
great.
what I will go through is a couple of text messages. Just the way that your mind thinks.
Oh, good.
That so
people are still trying to figure out what my mind
thinks. Merry Christmas. Merry Christmas, my friend. Working on our next episode. Got any good cases? And I said, you the one with all the good cases, player. How you feeling? And you're like, okay, my gallbladder hates me. I said, that sucks. Did you have a good Christmas? Yes, sort of. I can't eat anything with a lot of fat until they take this out. When you want to reschedule? Well, I got to text the surgeon, and then you go on to say about how sorry you are, and I'm like, get to feeling better.
Well, I felt bad. It was just such a bummer, and then when I guess Dr. Simpson told my boss that I was like a trooper that day. He's like, this girl was a trooper. You don't even understand. She looked terrible on Christmas Eve, and I was like, well, I mean, it is what it is, and we have a really great group there, and I mean, anyway, they were great to me. They sent my family dinner. They, didn't hurry me to come back. I'm very bruised up because, it was rough. There was a stone stuck in the cystic duct when they went in there and looked at it, and Dr. Simpson had to work on that. He had a lot of moving parts, like a lot of providers that were kind of like waiting in the wings in case they had to come in. And anyway, he said if I had waited 2 more days, I would have been really sick. So I was glad. I was thankful for him. He was wonderful. He's been wonderful to me. I haven't bothered him too much other than to ask him, like, when can I go back to work? And I think he's concerned about the soreness. Like, he doesn't want me to be running around there, which is fine. And I don't disagree, but it's hard for me not to be at my job. So it's big.
So no fat, like, until you had that.
Oh, yeah, like you knew you were going to have an attack if you had fat.
You would have had a rough time.
I did not have any fat. It was so pitiful because my mother...
We don't eat anything but fat.
Right. Was a wonderful cook. Yeah. My mother's a wonderful cook, and I could eat nothing on Christmas. But it's better. A lot of adjustments there. I did send Dr. Simpson a gift card for helping me.
Oh.
Look a little, something.
Was Christmas good for you?
It was. I had my kids, and... it was great, and, I spent
all that.
hours putting together weird toys and with strange parts and instruction pamphlets that are pages and pages and pages and pages long. So
got an email.
Okay.
At the 911 and the 864 at gmail.com.
Yep.
This is actually from a paramedic in the Prisma division. So
nice.
That means a lot to me that this paramedic reached out. Mike and Doc. As I was working today, I thought of an idea for y'all's discussion if you need one. The forgetting signs and symptoms. There are so many forgotten things that we could, if we all just looked around and within. Here's a little list of ideas I came up with to help explain what I mean. Some of them from my own curiosity, other are things I observed when she's done QA. I'm sure there are many more that I didn't think of that could be very helpful to refresh on or many. Skin color, condition, and temperature. We do not talk about this one enough. Initial sick or not sick comes straight out from here. Yes, it seems seemingly often forgotten and poorly documented in vital signs, or it's something people are doing but don't understand how important it is.
Right.
Oh, and cap refill. I love the way this is right.
Yeah.
Temperature, can you believe when we first put good thermometers on the truck, they told us to only use them when we suspected sepsis. Come on. TIMPs are such a non-invasive diagnostic tool that is used in the ER on seemingly everyone. Yet EMS people hardly document them on sepsis calls, let alone anything else. Entitled CO2, another good non-invasive tool that isn't used enough. You can talk about the good and the bad, how to address it, what you should do when your end tidal is showing 100s, what you should do when the end tidal is showing 0, after using 2 separate monitors, after extubation and re-intubation, both intubations, confirmed multiple times with video. That was a fun one. I love the way this is wrote. I'm going to have to reach out to her and tell her thank you.
Mm-hmm.
And I'll give you a backstory here in a sec. Lung sounds. I could definitely use a refresher on all those. I'm sure I'm not alone in this. Pupils are a weird and refresher on what makes them big and what makes them small, and the deceiving nature of opioid ODs, pupils not always being pinpoint. Abdominal assessment. We look, we palpate, we ask how it's feeling, but do we get the right picture out of the puzzle pieces that we are given to make the right differential diagnosis? Backwoods tips and tricks for knowing the difference between muscle, nerve, and bone injury. This one's for me and just my curiosity. Keep up the good work, Kaylee.
Well, that was a nice email, but she makes some extremely important points. Over at the Greenville County Jail, we actually, when we do QA, we have asked them to get a full set of vital signs. And that was like a huge undertaking. I know that makes no sense, but it's a huge undertaking to get them to do an O2 set of temp. But they've actually, we discussed the importance of knowing those, especially with sick calls or sick patients or whatever, and it was extremely helpful. But, and they've done a wonderful job of it. I think she makes a valid point. I will tell you that diaphoretic or pale skin makes me very nervous.
Right.
It's a huge part of it, and I agree with you about, agree with her about everything that she said. I think she makes a great list of suggestions.
So I reached out to her, and I was like, hey, I think this is amazing.
Yeah.
Kaylee works with our department. She does sepsis coordination within EMS. She does our QA for sepsis. She collects data for sepsis. So she's huge in that. So I reached out to her and said, give us some time for February, and we'd love to have her come on.
Sure.
And she'll be getting a challenge coin.
Oh, fun.
She will. As soon as they get finished, she'll be getting a challenge coin since
Great.
she submitted an email.
I think that's wonderful.
Okay.
I'd love to have her.
I would too. And I know she would love to be here.
Pupils are, this, we always had before the end title, before the bedside ultrasound, we always had this, like, the patient's fixed and dilated in a code. Then, that it would be. But apparently there's been a study that shows that at some point during a code anyway, they're fixed and dilated, and that means nothing. Which is actually terrifying to a physician who seemingly has to pronounce people all the time.
Absolutely.
Yeah, it was really interesting. So now they that is not really a reliable, which is actually also concerning to a paramedic that would call for termination efforts. Now, you wouldn't call based just on that because, of course, you have other things in your pocket, like, end title and other stuff like that. But I'm like, oh, dear.
How long ago was that when you...
It was just recently, like, it kind of came up in a discussion on MRAP. And then another person and I discussed it, and I just was like, I feel like we still hang our hat on that, right? Like, it's still in my notes. But I'm always afraid that somebody's going to sit up in the morgue. So I ultrasound somebody for an extended period of time when I call it in the ER because I don't want to be that person that it's like
it's a
I'm
common
terrified.
question.
Yeah, I don't want
25 minutes of aggressive resuscitation.
Yeah, you're just afraid,
In titles going down. First thing
fixed and dilated pupils.
Yeah,
fixed and dilated pupils.
Yep.
Yeah, something to dig into.
Content corner. I want to bounce some things off of you today because we talked about neuro.
Yeah.
And we talked about how some of the things we wanted to bring in, and obviously I wanted to make it relative to what we do.
Sure.
We go out, 61-year-old male, history of hypertension, No real cardiac history except for the hypertension, no stents, MIs, or anything like that. He manages it with lisinopril. Been feeling a little off for the past couple of days, just maybe some dizziness. We get out. Wife meets us at the door. We come. He's not pale, cool, diaphoretic. We get up with him, ask him some questions. We immediately notice there's some issues with his speech. He's hard to hear. So our differential highly on something neuro.
Sure.
We're thinking highly something neuro. We start to do our assessment. He's alert and oriented. We go in and we do our blood pressure. He's hypertensive at 190 over 100. Heart rate is 68 to 90, irregular. Do a Cincinnati on him. Unequal grip strength on the left side, slurred speech, and that's all we find at that time. We ask him to stand up, sit on the stretcher. We bring it right in there to him, and obviously we have to assist him with doing that.
Which is abnormal for him, I imagine.
Right.
At 61, he presumably, can walk around by himself normally.
Right.
Okay.
So we suspect that we have some type of neuro event, most likely a CVA.
Sure.
Stroke. He's still having symptoms. We check the blood sugar. It's 118.
Okay.
Check the temperature. It's 98.6. He does look AFib on the monitor.
Is that new?
Doesn't admit to history of
Interesting.
that.
Okay.
All right. So I've compiled all that together for continuum of care. Obviously, we know last seen normal 30 minutes ago.
Okay. Here's my question. As a physician, so just a couple of points. Like, yes, his blood pressure is high, right? But I always remind residents of this, and, we kind of talk through things. Like, yeah, his blood pressure's high. Great. You don't think he has a head bleed? Probably not, right? It's not like, oh my God, a headache, I'm vomiting everywhere. Not that all of them present that way. They don't. You could have a little micro bleed, but not like a major disaster. So, we don't really need to worry about that right now.
Right.
But you know what I mean? Just worry about that later. It's not 250. Okay, let's put that over there. The other thing now his blood sugar's 118. He's not a diabetic that he's aware of. That is an interesting point too, because in diabetic patients, 118 might be low for them. There's some people that live at 200-300. I've had that problem before in the ER, and I'm like, well, but their sugar's 120. Well, really, their sugar's normally 250. And we give them a little sugar and it resolves. That's not something that happens all the time, but it's something to remember. So I love the last seen normal question, because actually I like to be like an investigator when people answer that question. So last seen normal 30 minutes ago. Okay, but realistically, you haven't felt well for a couple of days. What does that mean? So I'm going to ask you, what does that mean when he says he hasn't felt well for a couple of days?
You want to know my opinion?
Yeah, I want to know what that means.
So, and that would be a question to ask him directly, is when you say you haven't felt well,
or his wife.
What be more specific?
Yeah, what does that mean?
All right, so it means that he's been a little dizzy for the past couple of days and just weak.
Okay, and that's abnormal.
Absolutely.
Is it generalized weakness or
generalized weakness?
Okay, not one-sided.
No.
And so, what time of the day is it right now?
11:30.
Okay, what time did he get up this morning?
9 o'clock.
Was he normal when he got up this morning?
He was.
He didn't have any dizziness. Wasn't weak. He was 100% normal this morning. That's what they tell you. So the dizziness and weakness comes and goes. Is that what he's saying?
That's what he's
comes
saying.
And goes. But he's normal until when? 30 minutes ago. What happened 30 minutes ago?
30 minutes ago, wife noticed he's having some slurred speech, and just something just doesn't seem right.
Okay. When was the last time his speech was normal?
30 minutes ago.
Like before that, he was fine, and then like mid-sentence?
She didn't even notice, like, when he was having dizziness, if
the speech was no different when he was dizzy, or whatever that was.
No, ma'am.
But he was dizzy now, for you. Yeah, so this is interesting. The other thing I actually asked people about last seen normal, and it's actually, you really have to hone in on this, and sometimes you aren't able to. But like what I've asked patients is, okay, what time did you go to bed? And they're like 10 p.m. I'm like, were you normal at 10 p.m.? Yes. What time did you get up? 7 a.m. Were you normal at 7 a.m.? No, I was abnormal at 7 a.m. And I'm like, did you go pee in the middle of the night?
Right.
And they're like, yes. I'm like, were you fine when you went pee? They're like, yes. I'm like, what time was it? Everybody looks at the clock when they go pee. Doesn't matter. Like,
Yeah, because you want to find out how much more hours of sleep you get.
right. So he was like 3 o'clock. I'm like, okay. So your last seen normal was 3 o'clock. Do you see what I mean? Other people that don't know and the family checks on them. Do you have a cell phone? When's the last time you texted with them? When's the last time you talked to them? And I will literally go back and it's been that serious sometimes because I'm like, no, I'm not just gonna say you're out of the window, right? I mean,
Right.
you have to like dig deep. Oh, did you talk to your neighbor this morning? Did you go out and get the mail this morning? Did someone see you? Did you talk to your daughter this morning? When's the last time you texted somebody? Do you have a cell phone? Like, I literally, unless I've exhausted all resources. Even at the nursing home, that's interesting, right? Their last normal is like yesterday. Well, not really, right? Like, when someone went in there this morning, were they fine? Yeah, they were fine. Did they eat dinner last night? Yeah, they ate dinner last night. Did you have to go and help them move around in the middle of the night? Did they go pee in the middle of the night? Look, I will call and ask all that because that's the, you can't just, I'm not saying that, TNK is like the magic bullet, but I mean, you just want to give everybody the chance that they can. So, all good questions. I'll tell you, I'm already concerned for a posterior circulation stroke. Dizziness is one of my major, makes me nervous. I probably overwork dizziness most of the time, which I think a lot of ER doctors do. It's actually one of the number one things besides MIs and missed fractures that we get sued for.
What are your differentials for this gentleman?
Okay, so of course vertigo's on there. Irritating. Regular CVA. Posterior stroke CVA. Is there some kind of weird tumor that's swelling in there? I mean, could it still be some weird hypertensive urgency that because he's for him he's so hypertensive? But I mean, common things being common. He's got AFib that's not diagnosed. Who knows when that started? Maybe that's what he felt weird for a couple days ago. I don't know. I suspect it's a stroke, and I suspect it has something to do with this back part, but we'd have to see.
What do you want to know from EMS? That's what I want to know. What do you want to know from EMS?
Are you asking this because you know that I've started a posterior stroke study?
No.
It's going live with Pickens County. Because this is one of my jams, is posterior circulation stroke.
No,
because the regular stuff. Now, this guy had a little bit of grip and in speech, which is actually leads you to the stroke thing. But a lot of posterior circulation strokes don't have that. And actually, you can go through whatever scale you want, and your number will be 0, and you will miss it.
So we've already talked about some of the interesting questions and how to get a more accurate last seen normal.
Right.
Those are things I would have never thought about. You get there, sweet little wife's trying to tell you everything she can. Well,
Wonderful.
did he pee last night?
Right.
Yeah, absolutely. He
he walked by himself.
Yeah. So I start to get a little bit better of a picture there.
Right.
Those are things I didn't think about from an EMS standpoint.
Yeah.
Very helpful tips. What I wanted to go through, because we've had some people reach out to us just saying that how good or bad of a job we do on a race score.
Oh, yeah.
So that's why
a race score will miss posterior circulation all day long.
Yeah, I wanted to make sure that we talked about that together. That's why I was pulling up.
There's 2 things that I will tell you are extremely important when you get a person that's dizzy or vertigo. Because somebody will tell you it's vertigo, right? Because they've Googled already before you got there. 1, walk the patient. If they normally can walk and they're ataxic, you should be concerned. They shouldn't be ataxic. Number 2, which is what we're piloting in Pickens County, is having, with a subset of various complaints like vertigo, dizziness, balance issues, double vision, things like that, we're having EMS do a finger to nose. Super easy test that they can do. No problem. I'm going to tell you, a finger to nose is going to be abnormal in somebody with they will not be able to touch yours. They'll be like this. Yeah. So that's what we're piloting, because we would hope to take this live and improve our ability from a pre-hospital, from a pre-hospital standpoint of improving our ability to find these.
So I'm rolling in with this guy.
Yeah.
And I see Fabs. She's an APOD.
Yeah.
She's waiting. Neuro team's
Sure.
down there with me. I've stroke alerted this guy.
Yes.
Last seen normal 30 minutes ago. He has been able to maintain his airway the whole time.
Sure.
En route. We've had no changes.
Yep.
We've emergently transported. I get there and I tell you this patient is, and give the report as what I've told you before.
Sure.
The extra things that you've told me that you want me to do that would be very helpful from an emergency physician. So some
Yeah, I'm gonna say like, hey, did you look at anything like finger to nose, or like is there nystagmus? That's another thing that's very posterior. And then, hey, how did he walk? Like normally, does he walk with a walker? Or no, normally he walks 5 miles a day and zips up the street. Okay, or he's still working full time. Okay, that's a big deal. So could he walk for you? And you're like, no. Like I had to like literally support him to like no, his balance is off. That's a big deal.
So then you go in and you ask, are you concerned about a race score? What?
Oh, yeah. I mean, we're still going to do the typical things that we normally do, which is like, he's going to go zip through the scanner and all that kind of stuff. It's just that that's an important additional piece.
Because I'm not saying it's new, but I'm going to be honest. When I was in paramedic school, we did a Cincinnati.
Right, yeah, of course.
And if it was,
right.
Positive or negative, whatever, that's the way, we went.
Yeah.
Race score's not new to us by any means, and we have them all on our ambulances.
Right
there sitting beside the provider. We can read it off, and we have a really neat sheet that we use, to ask questions and ask things like that. And I'm going to go through, and I want to bounce them off of you and I want you to kind of tell me what that is for you, because when I ask specific questions, okay?
Right.
So I brought this up on my phone just because it's hard for me to remember, right off. That's why we keep them on the side of the wall.
If you have to do the NIH stroke scale, which is what we have to do in hospital, it's like a ridiculous number of questions. So I get
first thing is facial palsy.
Sure.
I know what that, we don't really have to, it's kind of basic, is that we're looking for facial palsy.
Right.
We ask the patient to smile. He obviously has facial palsy. It's not extremely severe, so are we good to give him a 1?
Yeah, I think so. For minor?
Okay, so when you think about facial palsy versus minor versus severe.
Yeah.
And I can make faces, so like is this severe?
Well, you'll see patients with severe facial palsy and it'll be like this. And like just sitting there.
Do severe.
Okay. I can do it. Or you'll see patients with minor, like they presumably look normal, but you have them smile and it goes like this.
Okay.
And you're like, oh, okay.
So, you want to? Can I tell you a funny story? We had a completely, and don't forget where I'm at, because I will forget. We had a completely unrelated, not neuro. It was like nausea vomiting, and this patient, when I was assessing her, I had went and I was like, she has facial droop.
Oh dear.
And I was like, is this normal? And she's like, yeah, it's normal. And I'm like, this? And she's like, yeah, her face always looks like that. So anyway, I do a Cincinnati on her. Everything's fine, except for the facial droop. That is not changing. And I was like, so, but this is normal? And she was like, yeah, I seen a picture. And I look at a picture, and sure enough, she has facial droop in the picture.
Oh.
So I took the picture with me to the ER.
Oh, well, that's good, though.
I took the picture with me to the ER. Because I was like, they're going to get in here, and they're going to see this right here.
Yeah.
And they're going to be like, what? Oh, you need to go to CT now.
Right.
So I put that picture on her bedside right there by the tray and set it there. And I told that nurse where it was. So when the doctor came in, because I know that was one of the first things, it was one of the first things I honed in on. You know, and was about to go down a rabbit hole that I didn't need to go down.
Right.
I brought the picture with me.
The other thing about facial droop, just a couple things I've noticed. People that have like no teeth in, they will fool you too, right? Because they're like all sorts of all over the place, and they look at this. Then there's a subset of people that have Bell's palsy, and it's not anybody's job to figure out in the pre-hospital sector if something is Bell's palsy versus a stroke, and even sometimes it's developing Bell's palsy, which can throw everybody for a loop. But a generalized statement is lower half of the face, upper motor neuron stroke. Like consider that above. Lower motor neuron or after the brain is almost drooped the entire side, so they can't raise their eyebrow.
I don't know what
and they can't
that
smile.
means.
So think of it, brain problem, only lower face.
Okay.
If the whole face is involved on one side, it's after the brain.
Okay.
So
why didn't you say that to begin with?
I don't know, I guess. Just because I wanted to sound intelligent.
You're very intelligent. Moving on to arm motor function.
Yeah.
And all of these, except for gaze deviation, is going to be a 0 to 2 scale. I want you to explain that.
The gaze deviation?
No, I want you to explain why we can get a certain race score and not get a certain other race score. Why we can only get a certain race score.
What do you mean? Like
we can only get a 9, correct?
Yes. I mean, yes, more or less.
Okay.
Yeah. I think gaze deviation is a difficult thing, right? But I think largely what they're looking at is neglect, right? Like, you're, like, neglecting that entire left side. So you're, like, deviated to looking at let's say left side. So you would be deviated to looking at the right. It wouldn't matter what was happening over here. Your eyeballs would not come past midline.
And again, for quick review, if it's left or right, which side of the brain is being affected?
So usually the side opposite.
That's what I was
right.
Yeah.
Yeah, and then so gaze deviation is difficult too, right? Because you can also have like seizures that look like gaze deviation. There's a lot going on with gaze deviation, but it's generally for the sakes of the race score, they're considering it as looking at neglect.
Our motor function, we're 0 to 1 there. Obviously, normal to normal arm function. You would be able to raise your arms, squeeze. Maybe hold one there for a minute.
Right.
They obviously, the 1 to 2, if you can hold it there for a certain amount of time,
right.
you get a 1. If you can hold it there only at all, you get a 2.
Okay.
And that's what I wanted to kind of go through some of the specifics of that right there. When you go into arm motor function, being this specific race score right here, this cheat sheet here says holding it up for more than for 10 seconds.
Mm-hmm.
And you would get a 1.
Mm-hmm.
If you couldn't do it at all, you would get a 2. So,
right.
Leg motor function, again the same way, but it goes 5 seconds.
Mm-hmm.
5 seconds. So this gentleman right here, can hold his arm up for 9 seconds.
Okay.
He can hold his arm up for 9 seconds, and it just slowly starts to
he's got
fall.
pronator drift then.
Yeah, it
okay.
just slowly starts to fall down.
So it's abnormal.
All right, and then he can hold his leg up for more than 5 seconds.
It's pretty strong.
No.
It's not strong.
But
it has drift also?
Yes.
Oh, okay. Okay.
All right, so we're still thinking, what are we thinking on differential now?
Still stroke.
Okay, and we're thinking left arm, left leg that he can't hold up for a longer period of time. What are we? Does that cue us in on anything, or still just a generic CVA stroke?
I mean, it's probably right-sided.
Okay.
It's probably right-sided. What I think would be interesting is for us to look at this graphic of the brain for a minute. Okay, so interesting where you talk about localizing, and that's basically when they're asking you to do the arm and leg, and we're asking all this stuff as physicians because we're trying to localize where the lesion is, where the stroke is, right? So actually, and our viewers will be able to see this, I'm bringing up this part of the brain. If you basically stuck a Barbie doll down into the center of the brain, this is going to sound really gross when I describe it to you. It's going to sound a little...
Doll?
Well, I'm going to explain. Well, because she's got longer legs. So if you had her stand in the middle and bent over, I know, just stop. Bent over the side of the brain like this. Her and her hands at her side, it would line up with this.
Right.
Okay, so if you envision that all the time, you're like, okay, the face is on the outside, the arm is right here, the leg is in the middle. You can kind of localize. You'll see people that have strokes that are like, with like one arm down and some facial stuff, and their legs are totally fine. So you know that this section is okay. It's there that the stroke is. Do you see what I mean?
Yes.
Okay, so we'll put that in for our viewers. And I mean, that's literally what like one of our teachers taught us that. They would take like a brain model and stick the Barbie doll in and bend the Barbie doll over the side. They're like, this is the motor cortex. And I was like, like that was it for me. Because I was like, oh, yeah, okay, I get it now. Instead of trying to figure out, oh, well, this one is that, and this one's that, and this one's here, and this one's there. See what I mean?
Yeah, I see what you mean.
Is it weird? I mean, but it is. I mean, think about it, right? Their hands are, and the hand, like, why are these so big and some are so small? Well, here's the thing. There's a ton more nerves in the hands, in the face, than there is in the foot and the leg.
I'm gonna bring this up a little bit bigger so I can see it.
Yeah, this is another one. Same idea. All right, see, foot, leg, hip, their trunk, their arms and hands, their face. See that? Just bent right over. Boop. Boom. Mind blown. High five. Bring it in.
We're almost done with calculating our race score, which is
Yep.
huge to me because it's something that we can be a little bit better at. And then me and you are going to compete, and we're going to see what we get.
Oh, dear. Okay.
All right, aphasia. Aphasia, difficulty following commands. He
Doesn't sound like he's got that.
we ask him to close his eyes, and he does it.
Well, he could follow commands. Now, he could have weakness there, but he could follow commands.
We ask him to make a fist, and he does a slight
fist. So he
fist
understands what you're saying.
with his left side.
Right.
He does a slight fist. He is having a little trouble, though, with that left side. But right side, he's strong as an ox.
Do you think that the arm is stronger than the leg, or the leg is stronger than the arm on that left side, or is equally as bad?
I think the leg is slightly stronger than the arm.
Okay.
What does that mean?
I suspect it's more lateral. Like I'm honing in that this is more of an MCA.
Okay.
Yeah, but the leg is spared a little bit, not completely, but.
Ask him whose arm is this, and he said, "My."
Oh, he says no neglect.
Yep.
He knows it's there. Good.
All right. I point at his watch, and I say, "What is this?" And he says, "What?"
Good. He's doing well, actually.
What else do we want to know about him? Is there anything I've missed when I've done my race score eval?
Nothing in the race score, no.
Nothing in the race score.
No.
So as we're continuing care with this guy, as we get him into the hospital, you guys are doing like some kind of NIHSS.
Yeah, it's extremely involved.
NIHSS or something. What is it?
Well, it's so. I mean, you know,
you don't have to spend a lot of
the stroke time. Stroke people would hate for me to say this, but you know, the race score is like a mini NIH. That's basically what it is.
Right.
But you know, a lot of time when I do like my assessments real quick in the front, like of the ER or something like that, or at Greer when we have it set up a little bit differently, like the neurologist call back and like, "What's the NIH?" I'm like, "I have no idea. Didn't even calculate it yet." I just know it's a stroke because, you know, they have this. It's at least, you know, I can go through in my head and be like, they get this, they get this, they get this, they get this. And it's like, you know, it's at least 12 or something like that. Or, hey, it's only a 1, but here's why I think it's a posterior circulation stroke and not blah, blah, blah. So, you know, you kind of have to, you know, talk about it from that perspective. But
I'm going to go ahead and come up with my calculation.
Oh, dear.
And I'm going to give this to you.
Oh, okay, good.
And I want you to come up with your calculation, and let's just see what we have.
Okay.
All right?
Yeah. Okay. I was trying to zoom in. No palsy, mild. Are we saying mild? Based on what you said? Yeah, okay. So it's not like way down, just a little bit. Okay.
What'd you do on arm function?
1. I give him a 3. Is that the score you got?
I gave him a 3.
Yeah.
3 for Dell.
Sure.
3 for Dell. I gave him a 3. All right, so we don't suspect a large vessel occlusion.
Right. Which means you don't have to. Now, a lot of work. Recently they had a stroke symposium in December, and I actually did a lecture about EMS and strokes at that symposium. I would say though, people generally do well at a comprehensive stroke center, but not necessarily. It's not necessary. You know, unless we don't suspect a large vessel occlusion here. Not to say it can't be there, but we don't suspect it. So we need to go to the closest capable place.
Right.
So if you're out in the boons, you should probably go to the closest place that can give him presumably TNK. But anyway.
Okay. Well, it's something we don't think about in EMS. We're trying to do a one-stop shop, and we're, you know,
yeah.
But the fact that he does have what we suspect is not a large vessel occlusion, a low race score, and a good time, you know, a good history.
Right.
I think we get him to where he needs to be
Wherever,
and have a conversation.
Right. And I mean, like I said, there's a lot of moving parts of that. The literature does say that in general, people do well at a comprehensive stroke center. But let's face it, we're in the middle of a pandemic. We have high patient volumes. There's a lot going on with that. He doesn't need to be at the comprehensive stroke center at this point. Now, that may change, but at this point. So.
Well, I made that case up off the top of my head, by the way, because I wanted you to hear.
Well done.
Thank you.
Remember the nebulized ketamine discussion.
I do remember nebulized ketamine.
So
Because, as a matter of fact, I think we were both talking about trying to get an application to do that.
And then we decided that they probably wouldn't let us do that.
Right.
Okay, so apparently somebody else looked into that. Somebody else did a study of different doses of nebulized ketamine. So now we're just getting
We're getting in the
nitty gritty. But this was in an ER, okay, not in a closed box. Okay, so and basically I just thought I would update you as I find these. I think it was interesting. The conclusion was they didn't find any difference between the 3 doses of ketamine, and it was like 0.75, 1.5, and I mean mgs per kg. 0.75, 1, and 1.5. So really, you don't need to use a whopping dose to get the effect that you need.
Why is that, though?
I have no idea. I just found it to be extremely interesting. I was like, okay, it was. They actually did have good results as far as pain relief without any serious side effects or adverse effects. And what they did, the secondary outcomes included the need for rescue analgesia, so additional nebulized ketamine or IV morphine and adverse events. And the patients did well. So I thought it was interesting that, like, the dose didn't matter.
No matter what the dose that they gave?
Correct.
Like, they still maintained, pretty much the same medication?
Yeah. I think
and
this
all.
is just because I have another thing to talk about, too. But, yeah, it was very interesting. So,
But did they ever say, like, when they gave so they gave 0.7...
5 mg per kg, 1 mg per kg, and 1.5 mg per kg.
And no change.
There was no change. Didn't matter. I don't know if it has something to do with, like, how it goes in and how it's absorbed. I don't know. I'm not that smart, but I thought I would follow up.
Did they happen to say, like, what the patient... How the patient presented when they gave each of these doses? Like, I know it says the same, but...
No, I don't think so. Like, I mean, you mean injury-wise.
Right.
Like, was some disaster or not.
Right.
Yeah. I don't think so. But anyway.
This is really cool.
I thought it was an interesting follow-up. That was a little tidbit of one of these. And then I thought I would do a little bit of discussion about something that was interfacility, considering that we are in mobile care headquarters, and I thought maybe I should talk about, that's not really what your name, your Prisma Health Ambulance Service. Excuse me, but you're going to be mobile care for the rest of your life. But anyway, let's go to the next page. So I wanted to kind of come back around to that just to say that was still in the news. Next, so do you know what pre-patching means? If I was like, hey, do you have any idea what pre-patching is?
Applying a patch before...
Wonderful. Okay, I'm so glad it's not just me. But I don't have any idea. This is just done. This was like 2021. Anyway, it was a great article, but I didn't know what pre-patching was, and this was the impact of pre-patching on paramedic in-hospital time for emergent inter-facility transfers. Okay, pre-patching is apparently you contacting the facility, particularly the doctor, to discuss the case you're coming to get. Who knew? There's actually a word for it. Okay, I didn't know. So, the whole thing discussed all of this, and I'll tell you what they did. So, basically, underneath there, it says, we know that increased time of transfer, increased times in the ED, this is not rocket science. It takes you a long time to get the patient, or the patient's marinating in the ER, which is what, standard right these days in general. Increases morbidity and mortality. Time is brain, time is heart. Why wouldn't it apply here? I mean, it makes sense, right?
Right.
Longer they're somewhere without definitive care. So I also want to say that you shouldn't be sloppy or hasty, and make sure you think of the patient first, in general. Like, I don't want somebody to, like, go in there and scoop and run and be sloppy and hasty. Like, if you need a minute, you need a minute. But I think a lot of the time we lose sight of, we are not mindful of the amount of time it takes to transport a patient. It also applies to the amount of time a patient is in the ER without definitive care. Myself included, I think a lot of people that work in the emergency department, we get a disposition, we're like, all right, good, we have an accepting doctor, bing, and like, to us, like, the door goes down on that patient, we're like, all right, that's off our list. Like, no, it's not really off your list, they're still in your ER, like, what are you doing?
Can I ask a question?
Yeah.
All right. Reference pre-patching, just to make sure I fully grasp this.
Right.
This would be in use in a patient that, time is of the essence. And when we get there, in order to kind of cut down on some of our delays, that we've already had a conversation. Right. This patient is being accepted. That way, when you get here, this is what you have. And that way you're prepared.
Right, and I'll tell you exactly what they say. May clear it up for you. So, improving efficiencies in the interfacility transport process can expedite the time to critical treatment. Okay, that makes sense. Traditionally, paramedics would patch to a transport medicine physician, whatever, after initial patient contact. So, like, you've gotten there, you're going to talk to somebody about it. Okay, great. To discuss the case and expected management during transport, right? And I mean, for my patients that are being transported, I always talk. 90% of the time talk to the paramedics myself. I don't want the nurses just hand it off. I'm like, hey, listen, this is what I would expect. Blah blah blah. So, the objective of this study was to assess if pre-patching with paramedics prior to arrival at the patient reduced your in-hospital time for emergent interfacility transfers transported by a critical care transport organization. So you're talking critical care paramedics. They're going, this is not like, a broken ankle. This is like a pretty ill patient. So they did a retrospective study, which, I mean, you kind of have to do in this particular thing. And they basically looked at 10,000 patients. And they saw 3,000 plus patients have a pre-patch and 6,000 plus didn't have any. Ventilated patients and vasopressor patients were associated with a higher pre-patch rate. That makes sense. Like,
Right.
Okay. With the use of pre-patch increasing over subsequent years of the study. So additionally, patients required higher levels of care, blah, 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 whatever. Pre-patching reduced paramedic in-hospital time for emergency transports. Although the clinical impact isn't, we don't know what clinically, like how relevant is it. It seemed to cut down by 4 minutes. Now, you might be like, well, who cares? For 4 minutes for a stroke or 4 minutes for an MI, it might be serious. Actually, 4 minutes is a long time if you can think about it.
Yeah, I mean, 4 minutes you save with somebody in my family, I think it's a great idea.
So I think it's interesting. I don't know anything. I feel like we're going to definitely ask Aaron Dix if he knows what pre-patching means to put him on the spot, more or less. But so it basically means that the paramedics talk to the physician prior to even making patient contact. And actually in flight, this is what we do quite a bit. Actually, the fixed wing definitely does this. But, the helicopter probably doesn't have the time necessarily to do that. But this reduces in-hospital time, but it also provides a place for increased communication. And they also did comment on how it may be beneficial to patient safety and team performance.
I'd never heard of it until today.
No idea. Me neither. I didn't know either. But anyway, it was an interesting thought. And I thought, maybe we should discuss it since this is what you guys do here. Now, moving on to our case. I have two really kind of similar cases, but not, and I'll explain. So this was a patient that was a 60-year-old male that was brought in by EMS. It was Greenville County. They were called out for sciatica. It was Paul Pamiotto. You know him?
I do.
Okay. Of course it was him. Okay,
Yeah.
and I can't remember for the life of me who he was.
He works here part-time.
Yeah. Usually if Paul brings you a patient that... This is interesting, but I'll explain. So he was called out for a sciatica. Patient explains he's had sciatica and leg pain starting this week. And I'm going to tell you how it went. They're like, oh, he's got a little bit of flank pain. He's got some back pain and stuff. And the guy's like, yeah, it's sciatica, blah, 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 blah. Guy's like 60 years old. He actually, he had already seen his doctor about this. And he said he had a little bit of weakness, but he couldn't really elaborate in this leg, okay? Initially wanted to waiver, and it was Paul. Convinced him to come in. That's a huge thing to me. Like, the fact that Paul was like, there's just something about this that doesn't rub me the right way. That's literally kind of what he said. I'm turning on my heel to leave the room, and I'm like, wait a minute. When did you get sciatica? Or do you just, because people say, oh, I have sciatica, blah, blah, blah. No, he got sciatica that week. Oh, no. This is not what it is. So he's got flank pain, leg pain, cool extremities, and I ordered a CT. Do you have any idea why I ordered that CT?
No.
Okay, it's going to be his aorta. Hands down, it's going to be. There's flank pain and the sciatica he developed this week. Cooler extremities, and when he meant like weakness, it meant that one leg was weak. So you can go to the next page. That literally is his CAT scan. And it may be hard for you guys to see, and I actually had to circle it for Paul, but all of this, I'm going to show all of this here is blood. This is the aorta, is a AAA that ruptured. All of this is blood. See that?
Yes.
So he went promptly to the OR. He's okay, he made it. But he had tamponaded off that AAA rupture.
What a lucky man.
Yeah, no, he'd be dead if the paramedic didn't bring him in. So the take-home points was, consider this a diagnosis of new onset back and leg pain, examine the legs, because as soon as I touch the leg, I'm like, ooh, this leg is cold. Okay. I mean, but not like, oh, blue and it's icy, like cooler than the other side. Trust your gut. If something isn't sitting well with you, urge the patient to come.
And isn't that the fact that on that front side right there, isn't that a certain type of bleed or something like that? I don't know.
Yeah, and we're actually going to go over something like that.
Really?
But yeah. Overall, this man did well, thankfully. But it was when I turned back around, and I was like, wait a minute, when did you get sciatica? Now, if you told me you had sciatica for 20 years, I'd be like, okay. But he's like, no, my doctor said it's sciatica. I had it this week. I'm like, no, it's not.
Okay.
Yeah, no, it's not.
Did you already talk about the take-home points there?
Yeah.
You did. You mentioned them.
All right, so case 2, which is kind of the same. Actually, and I did call my friend in advance. I have a friend that's a nurse, and this is her mother-in-law. And this case happened right before Christmas.
Let me read it.
Sure. Go ahead.
Patient's a 61-year-old female who develops acute chest pain. EMS call, vital signs show hypertension, tachycardia, normal O2 sat, and temperature. Patient given nitro and aspirin, transported to GMH.
Right. She had some trouble with her leg as well, but does have this history of hip issues. She sounds wet on exam and then complains of abdominal pain. Okay,
Right.
So I'm going to walk you through what happened with this lady, and like I said, I did ask permission. My friend is a nurse at Greer, and I mean, God bless her. This lady's 61. I was working, and she's kind of talking to me in real time. She had called 911 herself. She happened to be at her mother-in-law's house when this chest pain hit. No real back pain per se. Had a little trouble with her leg. And then had complained in the ER by this point of she had sounded wet, but her chest x-ray didn't look bad. Had complained of abdominal pain, and at the same time, like this D-dimer came back, which I mean doesn't really matter, but it came back to some exorbitant a number. I said, "Oh my God, it's a dissection," and it turns out, and I said, "Go tell Dr. So-and-so it's a dissection." And anyway, we all kind of at the same time. She went to the scanner. She had dissected everywhere, and then she coded and died. It was awful. So it was really devastating for us. But anyway, she's got... So what I wanted to show you was... This is not her picture. This is just a picture I got online. This is a Dissection Ct, and you can see kind of like up there where it would normally be a really bright aorta like that. This is like if you cut somebody in half. You see a dark line, and then a dark line all the way down. So... interesting. There is a type A dissection and a type B dissection, and you can like further delineate it out that way. But for simplicity, if it starts, before the aortic arch and continues down, it's a type A. That's a surgical emergency. If it's a type B, like right at the arch peak lower, then it's medically managed most of the time. So, what I wanted to say was not to highlight, oh my God, this disaster, but yes, this aortic dissections and AAAs in general elude many providers. It just is what it is. But if you go to the next slide, my take home here is consider aortic dissection in any patient if they have a chest pain plus, meaning chest pain and back pain. Chest pain and abdominal pain, chest pain and any neurologic component. If somebody has chest pain and then they get facial droop, or chest pain and they have weakness, this lady had chest pain, and when I ended up talking to my friend, it was like lower extremity weakness in one leg. That is a dissection until proven otherwise. Period.
All right, go through those symptoms one more time.
All right, so
chest pain and back pain.
Yeah, chest pain plus, right? Chest pain and back pain. Chest pain and abdominal pain. Chest pain and any neurologic component, because they can dissect up the carotid. Right? And they can dissect down into the iliac, and they can dissect down to... So the abdominal pain component is, as it continues to dissect down, yes, you're dissecting through all of those arteries that fuel your gut, but you're also subsequently clotting off stuff, and then you get no flow. The other thing is to consider is like, when you have an aortic dissection, and even when you operate on the aorta, is that your spinal artery is also affected. And so if that's happening, then you have, paresthesias and stuff. If it's a chest pain plus, your differential should be dissection until proven otherwise. And that means when you hand that off to the doctor, you say, listen, this is chest pain, but they also have abdominal pain, or chest pain, back pain, or chest pain and this neurologic component. I really worry about dissection. I'd rather have somebody tell me something, even if it's wrong, than delay something. If we're going to get a CT and, angio, which is what you need to get, and have the cardiothoracic team on high alert, then that's what we have to do.
What are you guys doing for these patients inside far as surgery? Where are you starting?
They're doing all like grafts and everything else, but I mean the mortality on these is huge. But John Ritter, right?
Yeah.
Dissected. They thought he had the flu. He dissected.
Consider aortic dissection in any patient if they have chest pain plus, meaning chest pain and back pain.
Right.
Chest pain and abdominal pain.
Yeah.
And chest pain and any neuro.
Yeah. That shouldn't be. Right.
I like that. Thank you.
Yeah.
We are getting into the end of our episode today, which was neurological, along with some interesting cases as far as ketamine. We're trying to get signed up. Get us signed up.
Get us nebulized.
Yeah, get us signed up on that.
Right, right.
We can be betas. But I wanted to talk about hypertensive crisis real quick.
Oh, yeah, that's always a good one.
Moving back a little.
Okay.
Just because it is things that we can make a big difference in as
Right.
far as neuro. There's not much where we can make a big difference in except for time, but I want to talk about treatments as well.
Sure.
So we go out and we got this a 42-year-old male. We get out. He is complaining of dizziness and a headache. Says this started probably about 2 hours ago.
Mm-hmm.
He was at work. Pink, warm, and dry. Maybe the face is a little red. We take his blood pressure. He's like 230 over 120.
Mm-hmm.
Headache. A little bit of vision changes, but nothing really significant. Dizziness, though. So we go in and we're going to treat for hypertensive crisis. So me, personally, just from a 911 standpoint back in the day, we're going to go in. This is just me. And you tell me what you think about it. This blood pressure is dangerously high.
It is.
He has symptoms associated
Yes.
with it. The first thing I do after I clear my 12 lead out, I maybe show some LVH. It's unremarkable.
Mm-hmm.
First thing I do is go ahead and throw on an inch of nitro paste.
Yeah.
Do you want to ask me why I throw
Sure.
on an inch of nitro? And then I want you to weigh in on it. So people that are that hypertensive are tough to get to that catheter right where you need it to be in that vein, just because.
Sure.
So I first want anything that I have within my toolbox to assist me.
Okay.
And nitrates is all I have. Reference paste. I'll go ahead and throw that in and start letting it marinate before I go ahead and try to start my IV. What do you think about that?
Well, of course, I think you can do some interventions before you start your IV. There's a couple caveats here. Would you be wrong to do nothing? No, you wouldn't be wrong to do nothing. I mean, he's not acutely stroking out, I guess.
Right.
With the dizziness, who knows what that means? Is it lightheadedness? Or
Right.
You kind of have to
Right.
dig through that a little bit. But the other thing is, who knows how long he's really been that high? And I always get nervous about acutely dropping somebody too quickly. So that's something. Nitro is, I certainly like it. I mean, in the hospital setting, I may put him on Cardine, or something like that. However, again, I've used paste. I'm not going to say I haven't. I've used nitro drip. I've used sublinguals. The question is, how titratable is a paste? And it's not, right? So then I worry, like, are you going to get a rebound? There's that, but then are you also going to drop him too quickly and that kind of thing? I don't really know if you can say a tablet's titratable, but you can repeat it and things like that and recheck.
Nope,
Sorry.
you're good.
Something to consider. I mean, yeah, I don't think you would be wrong in that. Some doctors are not going to like that idea. They're probably going to think that we don't need to do anything but transport the patient. Now, if you had a long transport time and, that's pretty high, I mean, can you give them like a sublingual nitro and recheck and just kind of see things like that? Sure.
I was working with a paramedic student, and we had a patient with hypertensive crisis that we were going to throw on an inch of nitro paste. They had symptoms, and before they go in, they start getting their IV, because that's what they do. They love to start IVs. They want to start IVs on every patient. It's cool. They get to learn, and things like, hey, just my opinion, you want to go in and throw on like an inch of nitro paste so we can go ahead and start getting maybe that blood pressure down just a little bit prior to getting our stuff rigged up. And I always thought, I thought that made me a genius, but it doesn't. It's maybe not even that genius. But I was
I
thinking...
didn't say that. I just said you just have to be careful. If you drop somebody too fast, then they're going to have a stroke, because their body is used to perfusing at 190. They just happen to be 230 today. And then you drop them to like 120, they're going to...
Well, an inch of nitro pace. If I just throw that on there, typically maybe I get them down to about 190.
Yeah, sure.
190
I mean, you
over
can...
100.
Sure.
My IV attempt may be a little bit better then.
It might be.
How they are, man. When they're that hypertensive, that thing's...
Yeah,
Woo.
you're right. You're right. It might be.
I think I'm a genius.
I think you're a genius. Good tidbit.
Anything that we want to talk about before we...
I don't think so.
Obviously, we want to show appreciation for people that support us. We appreciate everybody that supports us. Keep watch it. We don't care if you take the quiz or not. We really want you to get credit for it, but at least watch it. Oh, looks like the boys are going out.
All right.
Yeah.
Oh, dear God.
Man. Oh man. Is there anything you want to say, Fabs?
No. Thank you so much for watching.
Hey, I'm glad you're feeling better.
Thank you.
But don't ever say sorry again when
I
you're
won't.
basically
I
a
know.
medical emergency.
Yeah. You probably shouldn't take Advil for a medical emergency either, but...